again, something which is close to my heart, as you said before, Dr. Kulkarni. It's the international exams, and I had the privilege of being in Korea last week to talk about the international board exams. And so I have an advantage in that, perhaps you have an advantage as well, that you know, I've actually practiced this talk a lot over the last couple of weeks, and this is my home. This is Adelaide. For those of you who know what cricket is, cricket was played around the world. This is the Adelaide Oval. This is the new building, the University of Adelaide building, and this is where the dental hospital is. And this is the view from just outside of my office. And so we have 4 seasons, and currently we're in the middle of winter. So we're looking at a dark winter. This is just some of the late autumn storms as they roll in through Adelaide. That is not a river, it's actually a lake. It's ornamental. It provides no water to our city. And if it wasn't for a dam at one end, there'd be a small creek that runs through Adelaide. So Adelaide doesn't have enough water to actually sustain itself as a city without pumping from a long way away. And that's not due to anything except from poor planning. So it's unfortunately, we have to take responsibility for our own actions, and that's the way it is. So I thought I would have a brief talk about our history, our current examinations, and our future. So why are we here? And really, the International Board owes its existence really to the International Association. We're an offshoot from the International Association, so we are not joined to them. We have no financial interest with them, apart from, you know, some assistance in our budget. We have our own office. We have our own budget. We have our own independence. So there's no political interference with our examination process by any means. So we look at an international certifying process, capitalizing on the resources and expertise and independence of that community, the international community, to provide a fair and unbiased evaluation of individuals' candidates' skills and knowledge. I first started with the International Association nearly 25 years ago, and I sat on the Education Committee. And at that stage, the Education Committee in the International Association was looking at accreditation of training programs. How can we improve the standard of oral and maxillofacial surgery training around the world? And initially it was felt that perhaps we should accredit training programs. Politically, that is suicide, because nobody is going to allow any group to come into their, into their area and say, I'm sorry, but your training does not stand up to scrutiny. You know, we'd be left out of the place, even though that might sound like it's a good idea. It really is not something that politically could be done by anybody. You know, even within your own country, you'll find that accrediting bodies often have a very poor reputation or a poor relationship with various institutions. You can imagine what would happen if people from other countries came in to accredit training programs. So we said, okay, well, perhaps we can accredit candidates, or we can examine candidates to a standard. And then we can use that qualification to say, okay, these people have achieved what is recognized as an international standard in oral and maxillofacial surgery. So we felt the benefits of an international certification was in the promotion of global standards. And we needed to develop what those global standards were. And fortunately, the International Association and the Education Committee of the International Association had already done that. So we looked at what constitutes an oral and maxillofacial surgeon around the world. We then looked at elevating local standards in training and certification of the specialty by promoting international collaboration, but by leveraging local strengths and capabilities that were already present within the areas that we were going to look at going. So we had this concept of local eminence, that is local on a national or regional level, and looked at what their definition of a specialist was. We looked at local definitions of scope, both core scope and expanded scope. And then we looked at this comprehensive scope, which included both core and some aspects of expanded. We left local control over licensure and admission for licensure to the local group. We can't do anything about that. You know, we're not there to tell people that we should be licensed to do this and that and the other, but we will gladly look at groups and interact with them to say, look, we are providing this, and this could be used for your local groups in licensure. So we wanted to preserve local certification and reinforcement that the international certification doesn't replace local certification, but perhaps will be an add-on. We had a lot of discussion about what we were going to call ourselves. You know, initially we wanted to call ourselves something simple, like the International Board of Oral and Maxillofacial Surgery. Fortunately, the name was already gone. The Indian Board of Oral and Maxillofacial Surgery already existed. And so, you know, that was already out there. We couldn't use it. So we became the International Board for the Certification of Specialists in Oral and Maxillofacial Surgery. And it was important that we differentiated ourselves. We were there for the certification of specialists, not specialist certification. So we didn't take people who had trained and said, okay, you are fit to be a specialist. What we have taken is people who are already specialists and said, you satisfy the criteria of the international group of being an oral and maxillofacial surgeon. And we can use that to say, these people are oral and maxillofacial surgeons, and they will be recognized as oral and maxillofacial surgeons around the world. So our certification process was this. It was not just an exam. Again, if we just ran an exam, we might as well run an association or a club, because it really didn't give us much more than, you know, any other exam. Anybody can sit and pass exams. Before people sat the exam, we needed to be sure that they had at least a minimum of 3 years of formal training. That is after a dental and or medical degree. We didn't discriminate. There are places in the world that a medical degree was required, other places that a dental degree was required, and other places that both degrees were required. The training had to be formal. It needed to be a proper training pathway. It's not, I did 6 months here with this doctor, I did another 6 months here with another professor, I did a year here with somebody here, I did 16 weekend courses, and I did something else. That is not a formal training pathway. We check all of the training pathways, so people who come to the exam have been through a pathway. We contact that pathway, the institution, the local group, to see whether that is recognized as a training pathway. The candidates need a minimum practical experience in a logbook. So we examine the logbook and we determine whether they are currently in scope of practice. And we've knocked back now quite a number of people who clearly, you know, they've got 10,000 cases in their logbook. Unfortunately, 9,999 are dental alveolar cases. That is not what we classify as an oral and maxillofacial surgeon. We need a spectrum of cases that go across our spectrum. Now, we don't need, you know, masses and masses of every spectrum, but we need a spectrum of cases that determines we are oral and maxillofacial surgeons, We're not oral surgeons and we're not dentists with a special interest. And we would like to see the specialist designation or license in the country that these people are coming from. Now, some countries don't have that, but there is a recognition of the specialists within the association of most countries that we deal with. So after we're satisfied that these people have done all of that, we then do a fundamental knowledge test, which is a computer-based MCQ. This is our didactic knowledge, it's in English, and is run through a secure testing center. Again, we're in English. We are not testing the English language. We are testing facts to do with our specialty. So the questions have all been rigorously looked at. They have a single stem and a single key. That is a statement and a single correct answer, and 3 distractors which are parallel to the single key. No double negatives, none of those really long questions. We want a single fact, a single answer. We then do a clinical practice test, which is an oral examination, 3 examiner panel, and there's 2 of those tests of 45 minutes each. We try to get at least 1 native speaker with standardized cases. So we have 12 cases overall, 3 examiners, 72 pieces of information that we're gathering. Diagnosis and treatment planning, that's all we're gathering, 2 pieces of information per case, per examiner. And on that, we can then look at the psychometric evaluation of those particular exams. So we can psychometrically test our examination, make sure it's valid. We can psychometrically test our examiners to make sure that they are providing an equitable examination. And again, we've had to move examiners on that are not demonstrating the fact that they're fair or equitable with the candidates. This is what we determined, or the International Association had determined, as the core OMS activity. And you can read all of those, basic sciences right down to orthognathic and orthopedic facial surgery. And as you know, there are a lot of places around the world that do more, but we would feel that there should be no places that do less than those core activities. And then the expanded scope, there are places that do all of these sorts of things within oral and maxillofacial surgery, but we're not going to examine to a high level. We would just expect our candidates to have a knowledge of these areas, but not necessarily that great working knowledge that we would like for odontogenic infections, for instance. So we'd expect some people to know about outpatient anesthesia, and but we'd expect a detailed knowledge of odontogenic infections. And I will say that there were some arguments here. The Americans felt that everybody did anesthesia, and we said nobody does anesthesia apart from you guys. And so that got moved to one side. And that's probably still the same, that we need a knowledge of that, but we're not practicing anesthetists. And the Americans and in the US, there's a lot of outpatient anesthesia done by oral and maxillofacial, so they need to be both competent and proficient in that as part of their practice. It is not part of core OMS, we felt. So an exhaustive process. We have a Senate made up of about 12 members from all over the world. We have an exam blueprint, so that we take all of those core areas and we say, okay, the percentage of the exam that should be devoted to those core areas. We have an oversight committee that looks at that. We have about 30 examiners who have all written. These are heads of departments from all over the world that have written items for us. We put them into an item bank. We look at them. We edit them. We place them into a final exam. We give the final exam. We do psychometrics on those. We have a key verification, make sure the actual answer is the correct answer. And I can tell you right now that every single one of these questions is put to all of our examination panel. And we've had some great arguments about which is the correct answer. If we can't agree amongst ourselves, amongst those guys, we cannot expect a candidate to know the answer if we can't even know the answer. So we delete those questions. Once we have the correct number of questions, we then set a pass-fail point. And this is really a reference-based examination. So we compare the candidate to the standard. So theoretically, every single person could pass. And theoretically, every single person could fail. Fortunately, we've had the first, but we haven't had the second. So what is this psychometrics that we're talking about? It's just statistics. And please, I don't pretend to know everything about this, but I certainly know a lot more than I did 10 years ago about the field of psychometrics. And it's the theory and technique of measurement of knowledge and abilities provided in an examination process. And this provides data-driven information on whether a test is appropriate, and it can be used to use whether that exam does what it's supposed to do. Is it reproducible? Is it valid? And is it really testing what you think it's testing? So we need reliability and validity. So this is an oral case, for instance, and so we have a look at this question here, which is 908. And so every question gets a p-value, and the p-value should be generally in the range of 0.3 to 0.8. And a p-bis value is the value of, are the good people getting this question correct? And are the not so good people not getting it correct? Because occasionally you'll find a question that the good people will get wrong and the bad people will get correct. And there are a whole bunch of reasons why psychometrically that happens. One is that if you overcomplicate the question, then a guess sometimes is better than some knowledge. And so people, if they overthink it, will often get it wrong. In this question, the correct answer is D. P-value of 0.53 in the range. The p-bis value, 0.21, again, for the correct answer, that's great. And so if you have a look here, so this is the number of people that scored that question, the mean score, and on here I've purposely put it small because it's not really relevant. I don't want everybody to concentrate on those, but it shows the question test correctly. The smart people are getting it correct. The not so smart people are not getting it correct. And the distractors are fairly equal. So that somebody is not trying, because of the way it's worded, one of the distractors is not getting all of the answers. And every single question that we put forward has that analysis done on it. So we're trying to avoid converting questions from a 1 in 4 to a 1 in 2, because if you write a distractor incorrectly, then all of a sudden you may have only 2 distractors in the correct answer, or at worst, 1 distractor and 1 correct answer. And so basically people can guess that fairly well. And the questions need to be written so that it's difficult to guess the answer based on the way the question is written. As we all know, an oral examination is not as standardized as a multiple choice examination, but we do need to find out what people know. And this is where our examiner calibration is most important, because we don't need our examiners to be going off the beaten track. We don't want our examiners to be teaching while they're supposed to be examining. We also don't want them to be directing or doing anything else to the candidate that allows them to get some affirmation that they're going well, or not affirmation that they're not going very well at all. You know, we need to keep them structured and focused so that we know what they are doing. So we have the calibration for these exams for all our examiners runs longer than the exams themselves. So we usually have 2 days of calibration. And remember, again, these are very senior people from around the world. You know, people who you've seen in the literature: Bob Ord, Tony Pogrel, Mark Wong, people from Japan, people from India, people from around the world. We have currently 12 or 15 different countries that we're drawing exams from for each exam. And we need to get them to follow this scripted exam question. That doesn't mean to say we're robots, that we just got to ask a question and accept an answer. It allows people to tell us what they know. And there's often no correct answer here. There's a range of answers that we will accept. In order to get to this, we need unambiguous questions and excellent images. And the important concepts for our examiners is that, does this candidate meet the requirements of what we would classify as the minimally qualified candidate? Does this candidate meet the requirements for what we call an oral and maxillofacial surgeon around the world? We're not talking about the base skill set. We're talking about what a minimally qualified oral and maxillofacial surgeon looks like. We need to know what that candidate knows. We don't really mind what she doesn't know or he doesn't know, but we need to know what they know. And we've just started a higher level examination, what's called a certificate of added qualification, to determine whether a candidate meets the requirements of advanced practice in an area. And currently we're running oncology and reconstruction of that area. So the MCQ examination, 150 questions, 1 correct answer, 4 hours to complete the MCQ exam, but it's a 3-hour paper. But due to language constraints, we felt that we ought to give 4 hours. Part 1 score is combined with part 2. The oncology examination made up of 115 questions. Again, the same format as our general fellowship examination. And the oral exam, two sections, 45 minutes, 6 patient scenarios per section. And we have to encourage all of the candidates to provide a description of how they would manage the patient, not how they think we should be managing it. And that's often, you know, we get candidates trying to outguess us, you know, trying to guess where I'm from, how I might answer the question, and therefore they'll try and answer the question how I might answer the question. But really, we need to know how the candidate would manage the patient. We only rate 2 areas: the ability to gather relevant clinical data and reach a diagnosis, and the ability to develop a treatment plan and management. That's all we're looking at. So it's very, very simple, very reproducible. And as I said, it doesn't really matter whether our examiners are hard or whether they're not so hard. What matters for the examiners is that they're consistent, that they treat every single candidate exactly the same way and follow exactly the same principles. We also, as part of this process, part of the psychometric process is that all of the examiners also put a difficulty level. So we use what's called a modified ANGO scoring system, where the group of examiners become the expert panel and say, okay, we would expect 60% of our minimally qualified candidates to get this question correct. Or we would expect, this is such fundamental knowledge that we would expect 100%. Or this is really a little bit out there and maybe only 20%. And that sort of data is also rolled in to our psychometrics as to It's sort of a scaling system for our exams in psychometrics. We started this in 2015. This is our second exam, 45 candidates. 10 candidates were not from Japan. So Turkey, and you can see there, South Korea, US, Saudi, South Africa, Namibia. This was the reason I brought this one on. This is our worst exam in terms of pass-fail rate that we've had at 94%. The KR score is a reliability score as to how successful the exam, and anything above 0.8 is a very reliable, reproducible exam. So Bangalore, the same year, 46 candidates. 6 of them were not from the Indian subcontinent. Again, pass rate of 89%, reliability score of 0.86. And I will say that, you know, our exams, you know, there was quite a clear separation above that standard and below that standard. And the figures for those who are interested, our first exam in 2015, we had 150 multiple choice questions. After doing the psychometrics on those questions, 25 of them did not test well. They were not valid questions. So we removed every single one of those from the exam, so that only 125 questions were valid questions that we left in the exam. By the time we got to the end of 2016, we are doing slightly better. We got 150 out of 150 that tested well. If you have a look at these raw scores, or the percentage of correct, they're very, very consistent across there and across all of the candidates. So the English language as their first language didn't seem to adversely affect the candidates. So those people who did not have English as a first language were not adversely affected by the exams that were held in English. And again, this reliability above 0.8, you know, 0.92 is very good, and we'll see our online ones in a few minutes. But in the terms of the oral exams, again, where conversational English is required, very consistent scores around those 3 exams from 2015 to the 2 exams in 2016. So the subspecialty maxillofacial oncology and reconstruction exam, this has become quite a popular exam for us, because this is now being used in countries to provide evidence that these people have experience and knowledge of oncology and reconstruction. Initially only open to fellows of the IBCSOMS, but now open to non-fellows as a primary fellowship. It's the same format as our fellowship exam and has the same psychometric standards. However, the certification to sit the exam is very different. We have a very, very different certification process. The logbook is far more rigorous. We require at least 4 references and at least 2 years contemporaneous experience in the exclusive practice of head and neck oncology to sit the exam. So due to COVID, we were forced either to die or to look at some other way of running our exam. And so we ran our first virtual exam in 2021. We had people all over the world. I ran this from the same office that I'm giving my talk to now. I ran this examination, and I ran 24 examiners from 10 countries in 18 different time zones, all on one computer screen. And it sounds daunting, but it actually ran really, really nicely. We had 10 candidates, 4 head and neck oncologies from 4 different countries for that exam. And we made sure we examined our candidates at a time that was reasonable for our candidates. So we did not run the exam at 1 a.m. for a candidate. We ran it at 1 a.m. for our examiners, but our candidates were really between 9 and 5 or 9 and 6 or 7. So in our ESSEX exam, 57% of candidates never had taken a remote exam before, or 93% of them never had a remote oral exam before, but they were very satisfied with the process. And this is really where everything looks at what we're doing. Our exam in Osaka in 2016 cost us $100,000 to run. We were charging $1,500 per person, and we had 45 people. And if you do the maths, we did not get enough to even come close to covering expenses. Fortunately, the Japan Society kicked in $40,000 to help us run that exam. In Bangalore, total expense is $62,000. Revenue a little bit better with the 46 candidates, left as a small balance. So the exams don't make a lot of money. In our virtual examination fee, we were able to reduce our fellowship fee by 50%, down to $1,000. The expenses, we were able to remove some of our fixed expenses. Our psychometrics here are $6,000 whether we run 10 people or whether we run 50 people. Meritrack did not charge us for running the MCQ exam, so it's a little bit artificially low here, simply because Meritrack out of India did not charge, because we were developing this process with them. So as you can see, the profit on this exam was $21,000, and we'll use that profit to reduce these fees even further for people to be able to sit the examination. So to wrap it up, we've tried to make sure our Senate has a good broad base around the countries. India, Europe, the Middle East, everywhere around the world. We've had from Africa, Fade, who's on the call tonight, Kurt, Bhutto, who was just retired, and we're looking at making sure that we replace Kurt with another member from Africa to make sure that we maintain representation from the places that we would like to put our exam. Izumi Asahina is also coming for retirement, and we look to replacing Izumi with somebody from Japan also. And Joseph Skonars from Europe. We will look at a European representative, although the Europeans have their own exam, which is far more. They require both medicine and dentistry prior to them seeing the exam. The International Association has a liaison officer, which is Sanjeev Nair, and this whole process is run with a single part-time executive officer, which is Caroline Johnson. We have no office. We have the only fixed expenses we've got are our Microsoft Office license, our SMT, which is the Schroeder Management Technologies, which looks after our database, and then our exams. That's the only expenses that we run with. We're running a very lean office at the moment. And this is where our fellows are currently. And as you can see here, despite the fact that we've held exams in India and Japan exclusively, we still have people from around the world, and three from Western Africa, 2 from Southern Africa, 1 from the Northern African, 8 from the Middle Eastern areas here, 98 from India, and of course 4 from Malaysia, but also United States and Japan. Japan is our biggest area, Japan and Korea, and then United States as well. So that's a run through of what we're doing with the international examination board, and I'd be happy to take any questions from there.